Hi guys, so now we are going to cover hyperkalemia from Toronto notes. Hyperkalemia is when serum potassium is more than 5 millimoles equal per liter. Usually it is asymptomatic but may present with nausea, palpitation, muscle weakness, muscle stiffness, paresthesia, areflexia, ascending paralysis and hypoventilation. And if there is impaired renal ammoniogenesis and excretion and metabolic acidosis may also be a presentation for hyperkalemia. ECG changes and cardiotoxicity may also occur. There is peaked and narrow T waves on ECG and decreased amplitude and eventual loss of P waves. Okay, and there is prolongation of the PR interval and widening of QRS, eventual merging with the T wave, which is known as sine wave pattern. So there's tall P wave in hyperkalemia and loss of P wave. And the causes of hyperkalemia are divided into four: pseudo-hyperkalemia, increase intake, transcellular shift, decrease excretion. If there is pseudo-hyperkalemia, which is the most common type, may present with sample hemolysis or sample may be taken from the vein where there is IV KCl that is running, and there can be a prolonged use of tourniquet that may cause pseudo-hyperkalemia. Leukocytosis and thrombocytosis may cause pseudo-hyperkalemia. Sample hemolysis, which is the most common one, sample taken from IV KCl is running, prolonged use of tourniquet, leukocytosis and thrombocytosis. So these are the causes of pseudo-hyperkalemia. Now coming to the increased intake. Diet, KCl tablets, IV KCl and salt substitute may cause increased intake may cause hyperkalemia. In transcellular shift, there could be an intravascular hemolysis, rhabdomyolysis, tumor lysis syndrome, insulin deficiencies, metabolic acidosis, drugs, beta blockers, digitalis overdose, and succinylcholine. These are the causes of transcellular shift of hyperkalemia. Decreased excretion if there is reduced GFR, renal failure, NSAID in renal insufficiencies, normal GFR, but hypoaldosteronism may also cause hypokalemia. In hypoaldosteronism, there is hypokalemia with hypernatremia. Okay, now we come to the causes of hyperkalemia with normal GFR secondary to hypoaldosteronism. So as we discussed before, in hypoaldosteronism, there could be a hyperkalemia. So they are further divided into three causes: decreased aldosterone stimulus, decreased aldosterone production, or aldosterone resistance. If there is decreased aldosterone stimulus, it may cause low renin and low aldosterone in decreased aldosterone stimulus. If there is decreased aldosterone production, there would be normal renin and low aldosterone. In aldosterone resistance, there would be decreased tubular response. If there is decreased aldosterone stimulus, that could be in diabetic nephropathy, NSAIDs, and chronic interstitial nephritis (HIV). In decreased aldosterone production could be in adrenal insufficiency, use of ACE inhibitors, ARBs, heparin, congenital adrenal hyperplasia with 21 hydroxylase deficiency. Aldosterone resistance could be in potassium sparing diuretics and renal tubular interstitial diseases. So these are the causes of hyperkalemia with normal GFR secondary to hypoaldosteronism. So there's decreased secretion of hypoaldosterone, there's decreased production, decreased stimulus or resistance. Okay, and potassium sparing diuretics may cause aldosterone resistance like spironolactone amiloride. Now, approach to hyperkalemia is first take ECG, begin treatment immediately. If there's pseudo hypokalemia, we need to repeat blood test, and if this intake is increased, we need to hold exogenous potassium like peroral or IV. And also, we need to stop drugs like ACE inhibitors, ARBs, aldosterone antagonists, beta blockers, and NSAIDs, that may cause transcellular shift. And we need to determine the patient's eGFR. In patient with diabetes and increased potassium and hyperglycemia, just give insulin to treat hyperkalemia. Okay, so we know in diabetic ketoacidosis we give insulin that helps you lower the potassium because that shifts the potassium to intracellular cells. So insulin is helpful in hyperkalemia. Treatment acute therapy is warranted if there is ECG changes, that is tall T wave, and patient is symptomatic regardless of potassium. If potassium is less than 6.5, we need to do ECG and treat the underlying cause, stop potassium intake, and increase the loss of potassium. If it's 6.5 to 7, no ECG changes, add insulin to the above regime. If more than 7, then we need to give calcium gluconate to the above. Okay, so ECG changes, stop intake, then we need to give insulin is if it's 6.5 to 7. If it's more than 7, we need to give calcium gluconate. Okay, so there are further treatments that of hypokalemia. So that's on the right side. C big K drop is the mnemonic. C is calcium gluconate. B is beta agonist, insulin, glucose, K oxalate, diuretics, and dialysis. So these are the treatment options available for hypokalemia. Calcium gluconate stabilizes the myocardium. We give it IV. It antagonizes the hyperkalemia, induces membrane depolarization, protect cardiac conduction system, and it has no effect on the serum potassium. Its onset is within minutes, within 30 to 60 minutes, may require repeat dose during treatment course of hyperkalemia. So, calcium gluconate stabilizes the myocardium. Shift of potassium into the cells, as discussed before. Insulin, regular insulin, causes the potassium to shift into the cell, and we need to give dextrose 50 water along with that to prevent hypoglycemia. Its action is within 15 to 30 minutes, and monitor capillary blood glucose every hour because of the risk of hypoglycemia with insulin. Caution given with dextrose 50 water before or without insulin if hyperkalemia is severe. Hypertonic glucose increases plasma osmolarity and produces extracellular shift and may cause serious arrhythmias. Ventolin nebulized forms, onset within 30 to 90 minutes, stimulate sodium potassium ATPase pump. So we need to be very careful in patient with heart failure because it may cause tachycardia. Ventolin may cause tachycardia in patient with heart failure. Now, enhanced removal from the body. So urine, we can give furosemide or fludrocortisone. If we are suspecting aldosterone deficiency, we may give fludrocortisone. Otherwise, we may give furosemide. And then we need to give fluid along with that to avoid hypovolemia. And then in GI, we may give petromer, or we may give zirconium, or cyclosilicate, or sodium polystyrene sulfate, which is also known as K-oxalate. It is sodium polystyrene K-oxalate should be used with caution as they may lead to development of colonic necrosis or intestinal perforation. K-oxalate is associated with colonic necrosis and intestinal perforation. Osmotic laxatives like lactulose can support GI excretion of potassium in the form of diarrhea, and dialysis is the last resort in patient with renal failure with life-threatening hyperkalemia. So on the right side, it says the acute management of hyperkalemia. The purpose is to manage the acute condition. There are three principal strategies of stabilizing the myocardium: intracellular shift and potassium excretion, either by urine or by stool. So stabilizing the myocardium, we need to give calcium gluconate, and along with calcium gluconate, we can also give Ventolin. Yes, and doses can be adjusted, and we need to see if the ECG changes persist. There are concerns regarding calcium use in digoxin toxicity causing irreversible non-contractile states. No life-threatening dysarrhythmias occur within 1 hour of calcium administration. Then there is intracellular shift of potassium, which we do by giving insulin along with dextrose 50 water, just so patient does not go into hypoglycemia, and because insulin causes the shift of potassium into the cell, and it starts its action within 15 to 30 minutes. And there is little evidence to suggest that sodium bicarbonate has a role in management of hyperkalemia, except in case of concomitant metabolic acidosis. So if the patient develops acidosis where pH goes below 7, we may give bicarb. And then enhancement of excretion by giving loop diuretics and potassium sparing loop diuretic and sodium polystyrene sulfonate, K-oxalate. So yeah, that's about it. I hope that's helpful.